This is Selma Schimmel, and I am so very pleased now to be sitting with the co-director of the CTRC-AACR San Antonio Breast Cancer Symposium, Dr. Kent Osborne, who's also the director of the Duncan Cancer Center and the Lester and Sue Smith Breast Center at the Baylor College of Medicine in Houston, Texas. Hello, Dr. Osborne.
Hi, Selma. Glad to be with you.
Thank you. Every year, we've been coming here, I think, for like 11 years now, and every year you make time with your crazy schedule here to sit with us for a few minutes. Thank you so much.
You're welcome.
So last year was a transition for the symposium. I believe it was last year, or was it the year before?
This is our third year to be partners with the AACR.
Time flies, doesn't it?
Yes, it does.
So, and it really enhanced the presentations and the multidisciplinary and research element of the meeting.
I think so. The AACR brought in several elements that people seem to enjoy. It was their idea to do the educational sessions on Wednesday, which are getting very crowded. And it was their idea to do some of the basic science forums that we have at lunch. So yeah, they brought in, I think, a lot of neat ideas, and our idea was to bring a little bit more basic and translational research to the meeting. And
I believe there are 9,000 attendees, and is it across 80 or 90 countries now?
I haven't heard the final, although I suspect it's right around there. It has been for the last several years, but it was last year was 100 different countries were represented here, so it spans the globe.
It's the largest breast cancer meeting of its kind in the world.
Correct.
And I'm curious to know, as you go through the presentations from this year's meeting, what you feel have been the most important and what you walk away with, what you think will really impact the treatment of breast cancer.
Well, there's several, I think. And of course, we haven't seen all of them yet. But there have been a few already presented that I think are worth commenting on. There was a whole series of abstracts presented on the topic of obesity, and of course then there was also a poster discussion session where several posters were discussed. And this is becoming a big issue that I think many patients don't yet understand. It has to do with lifestyle, and it has to do with obesity, and it has to do with alcohol consumption, and it has to do with exercise. And in the past, we knew that these things were probably important for preventing breast cancer, that is staying thin, exercising, avoiding alcohol, even 3 drinks a week. Above that starts to increase your risk of getting breast cancer. But what we didn't know was that these things also influence your recurrence of breast cancer after you've had the disease. And I think this study after study now is suggesting that this is really important, and therefore things like reducing weight, exercising, moderate exercise, 20 to 30 minutes a day or 3 to 5 hours a week is enough, walking, and minimizing alcohol consumption can really have a major effect on your outcome.
I have a question about the alcohol consumption. How do you explain for European cultures where, let's say, wine is just a basic part of meals, if you're in France or Italy? How do you reconcile all that?
Well, it's a risk factor no matter where you live, I think. However, I think it's going to be compounded more in this country than in some European countries, where the risk of breast cancer, by the way, is just as high as it is in North America. The highest breast cancer incidence is in Denmark and Holland, as an example. But I think it's going to be compounded in our country because of our obesity epidemic. It hasn't quite yet hit some of the countries in Europe. They're getting there, but it's not yet, particularly in France, for instance. So if you've ever eaten in France, and I'm sure you have, it's great food, rich food, but they have very small portions, and they stay thin. They're walking to the markets every day. And so yes, they may drink their wine, but then they offset that by staying thin and doing other things that would be protective. Still, they have a very high risk of breast cancer also.
And when you speak about alcohol, is there a difference between, you know, the glass of red wine that has also cardiovascular benefits versus hard liquor?
Not in terms of breast cancer. It doesn't make any difference what it is. It's alcohol. And it's a trade-off. You know, I suppose if I came from a family where everybody died at age 45 of a heart attack, I might want to drink my red wine. On the other hand, if I was more concerned about a breast cancer risk, or if I already had breast cancer, then I would probably cut back to a smaller amount.
All right, so it's interesting that you brought up the obesity study because as we've been speaking with other medical oncologists, that has also come up as one of the discussions that, especially because we've only talked about it really in terms of prevention, but now it's prevention in terms of recurrence and those risk factors, and that's a really big difference. Other studies, I thank you for answering.
Sure, no, I think there's several others. There was another one presented just a few minutes ago called the Azure trial. And there's been several studies now looking at these drugs called bisphosphonates, and that are mainly designed to protect you from osteoporosis, and they have some anti-cancer effects in metastatic breast cancer. There was an important trial presented last year that showed that it would reduce your risk of recurrence if you had breast cancer. There was a trial presented today attempting to confirm that, and overall it didn't, but except in one subgroup where it did. And if you take both of these trials together, they suggest that if you're a patient that is in a low estrogen environment, you're postmenopausal for a number of years, or you're a premenopausal patient that's been treated with drugs that lower your estrogen level and make you postmenopausal, that in that situation, it might be useful and beneficial to receive these bisphosphonates on an every 6-month basis. These are normal drugs, as I mentioned, like Fosamax and Boniva that women take in low doses for osteopenia and osteoporosis. But in the breast cancer setting, they may have some benefit. But since these two studies included different populations of women and found slightly different results, we can't use that as confirmation. And there are several other studies looking at these drugs that are waiting to be mature and presented. But I wouldn't be a bit surprised if in the future we find that there are a group of women treated with specific kinds of therapy, which would also be an indication for receiving these so-called bisphosphonates as adjuvant therapy to prevent risk of recurrence or to reduce your risk of recurrence. And then finally, there's another one presented today that I particularly like because it in part, the design of it in part came from results in my own laboratory, and that is in patients with HER2 positive breast cancer, this breast cancer that we used to think of as being so aggressive. Now with targeted treatments, it's really less aggressive in many ways because it's so treatable. But what we and others have found in the laboratory is that if you just block the HER2 pathway with the old standby Herceptin or trastuzumab, it's pretty good, but it's not totally effective against blocking that particular pathway. But if you combine it with other drugs that target that same HER2 or that same pathway in a slightly different way, that it's much more effective. And we were able to show—
As a combination
therapy. Combination. We were able to show a few years ago that for the first time we could actually eradicate HER2 positive human breast cancers growing in a mouse model that we have. So a number of clinical trials were designed based partly on our results, partly on several other laboratories' results that were finding similar things. In the trial presented today, there are actually two of them, but one of them used the same combination, trastuzumab and lapatinib, combined with a chemotherapy drug, compared to the single agents combined with the chemotherapy drug. And the combination, as we saw in the laboratory, was much more effective, twice as effective in inducing what are called pathologic CRs, where at the time of surgery there's no cancer left in the breast. And so that was very exciting to see something that was confirmed. There was another similar trial using a slightly different combination that we don't think is as effective, but having said that, even there, and this was without any chemotherapy at all, had a 17% incidence of pathologic CR. And so I think these combinations of drugs that target HER2 are going to turn out to be much more effective than trastuzumab by itself.
We had the opportunity to speak with Dr. Edith Perez about her research, and I'd said to her, it's just pretty amazing the progress that's being made with these HER2 positive cancers.
There has been a tremendous, as I said, a few years ago, I'm a medical oncologist and I treat patients, and a few years ago we would see a HER2 positive patient and I would cringe because I knew that they had a more rapidly growing tumor that would be more aggressive. And but now I like to see them. It's almost like having an estrogen receptor positive tumor today, that we have so many things we can do about it, and the outcome is dramatically changed.
How frustrated were you regarding the research about the number of women, 50% of women who even have insurance, that just are not getting their mammography screening?
Oh, that's a major problem, and it's a problem in many communities, including our own in Houston, where it's supposed to be a great Texas medical center, which it is, but we have a very large number of underinsured or uninsured women, and that's growing, particularly over the last 2 years because of the crisis in the economy. But we have the same problem. That is, many women, particularly the underserved, don't get mammograms for a variety of socioeconomic, political, variety of reasons, educational reasons. And in one of our own hospitals, they present with, 60% of them present with stage 3 or 4 breast cancer. And that's a tragedy.
Yes. Last thoughts from you before you run off to, you're the man in demand.
No, I think this meeting has, so far I'm very pleased with it. It's been exceptionally good. There have been a variety of very interesting things presented. And I think that you hardly see anything now, as we only saw just a few years ago and for the last 30 years, just studies of random sort of application of various chemotherapy regimens, testing 1 drug versus 2 drugs versus 3 drugs in sort of a non-specific, unintellectually satisfying way, and seeing one report after another. Now we're really getting down to the science of the tumor and finding out what kind of tumor does this person have, what are the genetic pathways that are broken, which ones should we target for better therapy. And we're starting to see the fruits of that now, and I think that's going to continue over the next decade. And so I'm very excited about that.
Personalized medicine for breast cancer. Thank you, Dr. Kent Osborne, co-director of the CTRC-AACR San Antonio Breast Cancer Symposium. Congratulations on a successful 33rd annual meeting.
Thank you.
Pleasure.